Dear viewers, this is part 3 of the 3-part series on overweight in the Prescribon medical education series. Coming back to the discussion, sedentary lifestyle is a major cause of obesity. Regular physical activity and physical training are known to increase muscle mass and decrease body fat mass. Inadequate physical activity is associated with decreased muscle mass and increased adiposity. There is a close association between sedentary behaviors such as excessive screen time, example television watching, and obesity. About 25 to 30% of the energy used each day by the average person goes into muscular activity, and in a laborer, as much as 60 to 70% used in this way. In obese people, increased physical activity often increases energy expenditure more than food intake, resulting in significant weight loss. Even a single episode of strenuous exercise may increase basal energy expenditure for several hours after the physical activity is stopped. Because muscular activity is by far the most important means by which energy is expended in the body, increased physical activity is often an effective means of reducing fat stores. Abnormal feeding behavior is an important cause of obesity. Environmental factors are important as evidenced from the rapid increase in the prevalence of obesity in most industrialized countries, which has coincided with an abundance of high energy foods and sedentary lifestyles. Psychological and social factors may contribute to obesity in some people. For example, some people often gain large amounts of weight during or after stressful situations, such as the death of a parent, a severe illness, or even mental depression. It seems that eating can be a means of relieving stress. Childhood overnutrition may contribute to adult obesity. One factor that may contribute to obesity is the prevalent idea that healthy eating habits require 3 meals a day and that each meal must be filling. Many young children are forced into this habit by overly solicitous parents, and the children continue to practice it throughout life. The rate of formation of new fat cells is especially rapid in the first few years of life, and the greater the rate of fat storage, the greater the number of fat cells. The number of fat cells in obese children is often as much as 3 times that in normal children. Therefore, it has been suggested that overnutrition of children, especially in infancy and to a lesser extent during the later years of childhood, can lead to a lifetime of obesity. In fact, studies have shown that approximately 80% of obese children become obese adults. Genetic factors as a cause of obesity. Obesity definitely runs in families. However, it has been difficult to determine the precise role of genetics in contributing to obesity because family members generally share many of the same eating habits and physical activity patterns. Current evidence suggests that 20 to 25% of cases of obesity may be caused by genetic factors. The percentage of children affected by obesity has increased steadily in many countries, including the United States, where obesity prevalence in children has more than tripled since the 1970s. Adverse consequences of obesity. Mechanistic considerations. Obesity is associated with a wide range of pathologies that can adversely impact morbidity and mortality. As people become obese, one of the first and most prominent biochemical abnormalities that develops is the need for increased circulating concentrations of insulin to maintain glucose homeostasis. This state of insulin resistance generally worsens with a greater degree of obesity. It is more prominent when fat is distributed more centrally. Insulin resistance come hyperinsulinemia is likely to play a major role in the predisposition to metabolic, endocrine, and cardiovascular diseases seen more frequently in obesity and may even play a role in the development of certain cancers. The main sites of insulin action in the body are the liver and skeletal muscle. Thus, for insulin resistance to be discernible at the level of the whole body, the action of insulin must be disturbed in one or both of these tissues. It seems unlikely that an expanded fat cell mass would do that directly. How then does obesity lead to a state of insulin resistance? One hypothesis suggests a leading role for the inflammation that occurs in the adipose tissue in obesity. There are more macrophages, that is, monocytes emigrated from the blood to tissues, including fat tissue, in obese than non-obese adipose tissues. This is associated with higher levels of inflammatory markers in the circulation of obese people. The majority of macrophages in obese adipose tissue are found in clusters around dead or dying adipocytes. So it appears that these macrophages are clearing debris after cell death. This inflammatory state, the inflammatory process of clearing fat cell debris by macrophages, is probably linked to insulin resistance. How does obesity cause metabolic disease? Insulin resistance is one of the earliest complications of obesity and underlies and precedes many of its adverse health consequences. The disposal of glucose by muscle becomes less sensitive to insulin. The production of glucose by liver becomes less sensitive to insulin. This results in a compensatory increase in insulin secretion from the pancreas. There are two main theories for the association of obesity with insulin resistance. In the first, products of macrophages and other inflammatory cells that are more abundant in obese adipose tissue can disturb insulin action in the muscle and liver cells. In the second, as adipose storage deposits fill up, which is the usual storage place, they become less able to take on excessive calories and safely store nutrients in their adipose tissue. This excess fat ends up being stored as ectopic, that is elsewhere, in lipid in tissues such as muscle and liver, which are not primarily designed to store nutrients of this type and may be damaged by the nutrient excess. The second theory is more probable in humans. How ectopic fat leads to insulin resistance and other damaging effects is still a puzzle. Dyslipidemia. The insulin resistance of obesity is frequently associated with dyslipidemia, characterized by high circulating triglycerides and low high density lipoprotein cholesterol, that is LDL cholesterol. Occasionally, the hypertriglyceridemia may be severe enough to put the patient at risk of pancreatitis. There is a relationship between obesity and raised circulating levels of low density lipoprotein cholesterol, which is the major risk factor for coronary artery disease. Fatty liver disease. Obesity is strongly associated with the presence of ectopic fat in hepatocytes. This can progress to non-alcoholic steatohepatitis, NASH, which can progress to fibrosis, which is a precursor to cirrhosis. The reported incidence of NASH related cirrhosis and of hepatocellular carcinoma has increased markedly in step with the increase in the prevalence of obesity in adolescents and adults. Type 2 diabetes. The insulin resistance characteristic of the overnourished state strongly predisposes to the development of type 2 diabetes in people who, largely for genetic reasons, are less able to maintain the high levels of insulin secretion over many decades. Impaired glucose tolerance and type 2 diabetes are among the most common complications of obesity. Endocrine complications. In females, the insulin resistance cum hyperinsulinemia frequently found in obesity strongly predisposes to the development of polycystic ovaries characterized by irregular menstruation, anovulatory infertility, and hirsutism due to hyperandrogenism, that is, increased amounts of male hormones. In males, obesity is more often associated with a degree of central hypogonadism. Note: central hypogonadism is a clinical condition characterized by sexual symptoms and low serum testosterone levels due to an impaired function of the hypothalamus or pituitary gland. Dermatologic complications. Obesity can result in problems with excessive skin folds that can cause discomfort through mechanical irritation and can also become infected with fungi. Insulin resistance cum hyperinsulinemia is associated with acanthosis nigricans, where areas such as axilla, groin, and the back of neck develop velvety hyperpigmentation. Hidradenitis suppurativa is a potentially disabling skin condition strongly associated with obesity. It is characterized by recurrent boils, often with chronically draining sinus tracts, affecting skin areas containing apocrine sweat glands, that is, in the axilla and groins. Cardiovascular complications. Obese people, even if they do not have diabetes, have increased morbidity and mortality from atherothrombotic vascular disease, including coronary artery disease and stroke. The factors that result in this are complex and involve increased prevalence of hypertension, dyslipidemia, and insulin resistance cum hyperinsulinemia. Obese people are also at increased risk of heart failure, particularly characterized primarily by diastolic dysfunction and of atrial fibrillation, the most common arrhythmia. Respiratory complications. Exertional dyspnea is common in obesity, contributed to by the increased work required to move a greater mass, as well as impacts of pressure on the diaphragm and thoracic cage on chest wall compliance. Enlargement of soft tissue of the mouth and throat and adipose deposits around the airways contribute to the high prevalence of sleep apnea. Gastrointestinal disorder. Reflux esophagitis is the most common gastrointestinal complication of obesity, particularly occurring in those with high intra-abdominal pressure. Gallstones are also more common in obese people, bringing increased risks of biliary colic, cholecystitis, pancreatitis, and gallbladder cancer. Rheumatologic disorders. Osteoarthritis of the knee and gout are the two most common rheumatologic conditions clearly associated with obesity. Cancers. Obesity is a risk factor for a number of common cancers. Indeed, it has recently been calculated that, at least in some countries, obesity has overtaken smoking as the greatest risk factor for developing cancer. Recent research has found that as the BMI, that is body mass index, increases by 5 kg per meter square, cancer mortality increases by 10%. The largest effects are on colorectal cancer, kidney and pancreatic cancer, adenocarcinoma of the esophagus, and in women, endometrial carcinoma, that is cancer of uterus. The recent rapid increase in the prevalence of esophageal adenocarcinoma is likely related to the marked recent increase in reflux esophagitis due to the raised intra-abdominal pressure characteristic of central obesity. Response to infection. The fact that obesity can influence the outcome of some infections has become very apparent with the COVID-19 pandemic. Obese patients have a substantially worse outcome if infected by SARS-CoV-2 through mechanisms that are as yet unclear. Obese patients also appear to be more susceptible to bacterial wound infections and postoperative sepsis. Disorders of the central nervous system. There is increasing evidence that obesity is a risk factor for dementia in later life, although how that risk is mediated is not clear. Idiopathic intracranial hypertension is a rare disorder that is strongly associated with obesity. Treatment of obesity. Treatment of obesity depends on decreasing energy input below energy expenditure and creating a sustained negative energy balance until the desired weight loss is achieved. The current recommendation is a decrease in caloric intake of 500 calories, that is 500 kilocalories per day for overweight and moderately obese persons, that is BMI more than 25 but less than 35 kg per meter square, to achieve a weight loss of approximately 1 pound each week. A more aggressive energy deficit of 500 to 1000 calories per day is recommended for persons with BMIs greater than 35 kg per meter square. Typically, such an energy deficit, if it can be achieved and sustained, will cause a weight loss of about 1 to 2 pounds per week or about a 10% weight loss after 6 months. However, it is important to prevent vitamin deficiencies during the dieting period. For most people, increasing physical activity is also an important component of successful long-term reduction in adiposity. Almost all current guidelines for treatment of obesity therefore recommend lifestyle modifications that include increased physical activity combined with a reduction in caloric intake. See related video on exercise in Prescribon Medical Education series. Pharmacological management of obesity. Various drugs for decreasing the degree of hunger have been used in obesity treatment. The most widely used drugs are amphetamines or amphetamine derivatives, which directly inhibit the feeding centers in the brain. Bupropion, a dopamine and norepinephrine reuptake inhibitor, stimulates POMC neurons, that is, they are special neurons in the hypothalamus and brainstem, and is used in conjunction with naltrexone, an opioid receptor antagonist, to treat obesity. Synthetic glucagon-like peptides 1, GLP-1 agonists, a class of drugs used to treat type 2 diabetes mellitus, causes satiety and modest weight loss. The sodium glucose transporter 2, SGLT2 inhibitors promote mild weight loss by preventing reabsorption of glucose as well as water in the renal tubules and are also used in treating type 2 diabetes mellitus. Still another group of drugs works by altering lipid absorption by the gut. For example, orlistat, a lipase inhibitor, reduces the intestinal digestion of fat, causing a portion of the ingested fat to be lost in the feces and therefore reducing energy absorption. However, fecal fat loss may cause unpleasant gastrointestinal side effects as well as loss of fat-soluble vitamins in the feces. All of these drugs produce modest weight loss, usually only 5 to 10% or less in some cases. They are most effective only when used in combination with lifestyle modifications aimed at increased physical activity and a healthier diet. surgical treatment of obesity. For morbidly obese patients with body mass index greater than 40 kg per meter square, or for patients with BMIs greater than 35 kg per meter square, and conditions such as hypertension or type 2 diabetes that predisposes them to other serious diseases, various surgical procedures can be used to decrease the fat mass of the body or to decrease the amount of food that can be eaten at each meal. Gastric bypass surgery involves construction of a small pouch in the proximal part of the stomach that is then connected to the jejunum with a section of small bowel of varying lengths. The pouch is separated from the remaining part of the stomach with staples. Gastric banding surgery involves placing an adjustable band around the stomach near its upper end. This procedure also creates a small stomach pouch that restricts the amount of food that can be eaten at each meal. A third procedure that is now becoming more widely used is vertical sleeve gastrectomy, which removes a large part of the stomach with the remaining part stapled back together. These surgical procedures generally produce substantial weight loss in obese patients. The gastric bypass and vertical sleeve procedures often lead to rapid remission of type 2 diabetes mellitus and hypertension, important complications of obesity, even before substantial weight loss has occurred. These procedures are major operations, however, and their long-term effects on overall health and mortality are still uncertain. So, dear viewers, this is the end of part 3 of the 3-part series on overweight. For other videos, see Prescribon Medical Education series, especially the discussion on food balance and exercise. Thank you for watching.